questions. Lots has happened in the last few years with prostate cancer, and I'm trying to hit the high points and not keep you here very long. But in particular, for those of you who are in primary care, we'll go over some screening issues and then talk about the 3 or 4 new drugs that are adding to survival. And I've got a series of a sort of table that builds to show what's wrong with American medicine, and you all can decide how to deal with that. So this is a century of progress in prostate cancer therapy. It turns out the first breast cancer hormone treatment was in about 1894. And a woman who had breast cancer had an oophorectomy and it went into remission. And it was 50 years until the mid-1940s until somebody did an orchiectomy in somebody with prostate cancer. And that was Charles Huggins. And he first figured out that prostates would shrink in dogs. And I think one domestic, I think it was sheep or cows, I can't remember, and then said, okay, well that might work for prostate cancer. And then probably somebody, Patty knows, Bagshaw, started looking at using radiation therapy. Jerry Murphy was one of the first guys to use chemotherapy much later. But in general, prostate cancer sort of lags breast cancer by anywhere from 20 to 50 years. And it's been kind of frustrating. I like to say in breast cancer, they race for the cure. In prostate cancer, we crawl for the cure. So you can see that there's a lot of similarities. The number of new cases and the number of deaths are pretty similar between breast and prostate cancer, actually. So 2,200 deaths in breast cancer, 1,500 in prostate cancer. These are the number 1 cancers diagnosed. And actually, for both of these diseases, screening remains controversial. And I know a lot more about the controversy in prostate cancer than I do in breast cancer, so you can have Patty talk to you about breast cancer if you want. This peak in prostate cancer incidence was the discovery in the late 1980s of PSA testing. And PSA is a protein that's made by the glandular cells in the prostate. It's a kallikrein enzyme, and its function is to take the ejaculate and break down the proteins in the ejaculate so the sperm can swim out. And it leaks backwards across the basement membrane when there's invasion of the basement membrane and gets into the bloodstream. But the number 1 cause of an elevated PSA is a big prostate. So it creates a huge problem because somebody with an elevated PSA may or may not have prostate cancer. And in that sense, it's a rather difficult test to use. But this big peak, it turns out that over 50% of US males have now had some PSA testing and screening, and it was promoted by the urologist as the providentially sent antigen, and remains a major way in which prostate cancer is diagnosed, whether or not we need to diagnose it. So the lifetime risk of getting prostate cancer is kind of like breast cancer. It's 1 in 6 or so. But your chances of dying of it are only 3%. So there's been some estimates in various articles that are written that we overdiagnose prostate cancer because of PSA testing almost half the time. One of the articles that we'll go over in a little more detail shows that you really have to screen a large number of patients and treat a very large number of those patients to save 1 life. And the incidence and mortality is shown here, and you can kind of throw up high-fat diets and cholesterol. So here's Northern Europe, North America, Eastern Europe, Australia, New Zealand. I don't know if lamb fat makes it even worse, but it turns out that one of the examples that is always cited of why our diet contributes so much to this is following Japanese immigrants. So Japanese immigrants who marry Japanese women and have Japanese children who move to Hawaii pick up about twice the incidence of prostate cancer, and if they move to San Francisco, it goes up another 2 times. So the fat in our diets clearly contributes to this. And we have a lipid specialist at the university, sort of an aside, that was president of the American Heart Association, Bob Eckel. And I tried to get Bob, he's a lipid specialist, I tried to get him interested in prostate cancer for a long time, and about 3 years ago he finally came and said, I have a postdoc who might be interested in doing something. So Isabel Schlopfer has started studying this, and it turns out that prostate cancer is more lipid dependent for energy metabolism than breast cancer and a lot of other cancers. And we kind of know this because if you do PET scans, which are glucose uptake, and we know that cancers take up glucose avidly since the 1940s. The Warburg effect is this uptake of glucose with oxidative metabolism turned off and lactic acid being produced. If you try and do glucose PET scans in prostate cancer, they don't work very well. But if you do choline or acetate studies, which are lipid precursors in prostate cancer, those do work fairly well. And choline PET scans will be approved probably in the next year or two. In fact, I think they're already approved and you have to get a license. So the university is currently trying to get a choline license. It's a little different chemistry.
Mike, if you treat this, let me back up. Is it 3% of death if you do nothing, or is that?
It's just taking all the 2,000 patients who die of heart disease, stroke, or whatever. 3% of us die of prostate cancer. But most of us have prostate cancer when we die. So if you autopsy 90-year-old men, 80% or so will have prostate cancer if you slice through with 1 millimeter sections. And so that leads to the conundrum. If you drill more holes, you find more oil, blah, blah, blah. And that's exactly where we're at. So the hooker is, and you can spend hours talking about it. We'll go into it a little bit, but fundamentally, the big Nobel Prize will be for somebody who can figure out with a molecular technique, leave these 25 guys alone and treat those two. And that's a $64,000 problem. So T1 disease is confined to the prostate. Incidental finding on TERPs is T1A. The most common is T1C, defined by a needle biopsy because of an elevated PSA. That's over half the patients that we discover right now and that we go ahead and treat because in many cases, we don't know anything better. T2 is something you can palpate. And if it's in both sides, it's a T2C, and if it's one side, T2A, et cetera. T3 is where clinically you feel with a digital rectal exam that the cancer has spread outside the prostate. If you've got appropriate anatomy and long enough fingers, sometimes you can feel extension into the seminal vesicles, which is T3C. And then T4 disease is when the prostate becomes immobile and is attached to the bladder neck or has spread to the floor of the pelvis, et cetera. So that's the staging system. And nodal disease, N1 is a single lymph node area, and we see that fairly frequently. If it's in one or more regional nodes that are big, it's N2. We don't see that too often. And large lymph nodes are pretty unusual, even in advanced disease. There's a kind of interesting anecdote. We were just talking about one of our patients who died. We've had, I think, 2, if not 3 patients die here in the last month or 2 with explosive disease. And the drugs that I'm going to talk to you about have changed this. I was at a Department of Defense meeting, Prostate Cancer Clinical Trials Consortium for a week ago today. It was at Hopkins, and everybody's seeing this. So these new drugs are able to keep the lid on the testosterone androgen receptor axis for an extra year or 2, and then the disease just takes off and people die in a very short period of time. Patty saw one of our patients about a month and a half ago, and as usual, she's a better diagnostician and clinician than I am, and said he's got a rash that looks to me like high bilirubin. Well, it turned out the bilirubin was normal, I might add. But, but she was right, he had liver disease, and his liver he had basically replaced his liver with prostate cancer in less than 6 months. And it was just and he died 2 weeks later. Very explosive disease. So even the clinical presentation, how we treat it's changing. We'll go over a couple of these screening trials. This is the one from the United States, and it was updated this year, but it was first published in the New England Journal. But the PLCO, prostate, lung, colon, and ovary screening program, randomized 77,000 people to, for example, you could get screened for colon and prostate, but not for lung, or you could get screened for ovary and lung, but not for whatever it was. So there were controls built in by being screened for 2, but not all 4 diseases, and of course ovary and prostate are gender specific. But In the prostate area, 76,000, 38,000 allocated to control and intervention. The biggest critique of this was there was over 50% contamination of people who went to the Channel 9 health fair and got screened anyway. So it made it hard to interpret this particular study. But anyway, they looked at the outcome, prostate cancer during 13 years of follow-up, 3,800 cases here and 4,200 cases over here in the screened arm. And the outcome was 158 deaths in the screened arm and 145 deaths in the cancer arm. So certainly not a huge impact on screening all these people at enormous cost. And looked at graphically, this is the cumulative number of prostate cancers. And you can see in the screened arm there were more cases that started off very early and stayed separated all the way through the study. But the death rate was not very different. The cumulative number of deaths among screened patients and among control patients, these are deaths from prostate cancer. This was statistically not significant, but if anything, the screened patients had a higher death rate from prostate cancer. So that was one of the two very large studies that was done. This was the one done in Europe. This had 65,000 and 80,000 patients that were followed for a period of about 10 years. Well, I guess some people out to 14 years. This study did show a statistically significant drop in the cumulative hazard of dying from prostate cancer among the screened group, but it was statistically significant, these curves are not terribly different. And in that particular study, they looked at what was the overall impact of doing this, and this was the New England Journal article from 3 years ago. You'd have to screen 1,410 men, find 48 additional cases of cancer that you wouldn't have found otherwise to prevent one death from prostate cancer. So pretty inefficient and creates a huge conundrum for what we do. I thought I could find some program that would do this, but this was hand-drawn. I made little circles and then pasted them together and then bigger paste. And then I colored these. But this is what it looks like. 1,410 men. This is half that number, graphically illustrated. 48 treated, so there are 24 here to save this one guy's life, or 12 here, I guess. So that's sort of a huge burden of health care with a very minimal impact. Well, because of that, the U.S. Preventive Services Task Force gave this a D rating, which means not to be used. And in fact, just in the last year or so since this came out, the number of patients being screened for prostate cancer has gone down dramatically, and the urologists are all up in the air about it. We'll look at some of that. So they felt that prostate, so you can actually go to this website and hand it to your patients, and they've got stuff that's patient-oriented, that's quite good, recommended for adult men of all ages, doesn't apply to men who've been diagnosed with prostate cancer, and concluded the expected harms of PSA screening are greater than the expected benefits. And the family practice associations and all that were, behind this. The urologists went nuts. There are a lot of problems with treating prostate cancer. There's no free ride regardless of whether you do active surveillance or get surgery or radiation. Erectile dysfunction from any of the treatments, including hormone therapy, is there. Incontinence, especially from surgery, is significant. They didn't put it here, but it's sort of a trade-off with radiation therapy. There's usually bowel and bladder urgency that can get bad, and most patients get over those, but small risk of death and complications from surgery. So if it was an easy, as my own surgeon said, if the prostate was located near your elbow, we'd take it out and everybody over the age of 50 who's already had the children that they want, but unfortunately it's not located there. The other issue that has come out in this screening is that people keep screening. So there's been a lot of criticism of screening older men. And in fact, in our own institution this year, in our September Prostate Cancer Awareness Week screening, an 84-year-old guy came in who bragged that this was his 20th successive year of coming to our screening program, and fell over in the bathroom and struck his head on the toilet and had a huge laceration. He didn't die, but he could have gotten killed by being screened. And we can't. Terrible. So anyway, so some of the critiques that came out were the U.S. Preventive Services Task Force didn't have any prostate cancer experts on it. So my frenemy, Dr. Crawford, and a bunch of other people who like to get their name in the paper, said, you know, you really should have people who are experts in the disease as part of these panels, and admitted that the utility of screening decreases with increasing age. This was Otis Browley, who's president of the American Cancer Society, and an African-American guy. He's a good guy, actually, and said the time has come when a small group of experts can meet and in short order develop rigorous guidelines is coming to an end. And, you know, because the experts aren't involved, not everything is considered. So this was the PIVOT trial, which was published in July of this year, which was radical prostatectomy versus observation. Now, this was a study in VA patients, so older, sicker population, so you have to keep that in mind. And it's not a huge study, but 10 years of follow-up, 171 of the 364 men, 47% assigned to radical prostatectomy died, as opposed to 183 of 367, 49% assigned to observation. So there was no difference in treating people and not treating people in terms of dying. And that's because, of course, when you get to be 75 or 80, something's going to kill you. You die of something. So there was an 2.9% absolute reduction in death rate, and a slightly higher than that, 5.8%. So it's about a 3% difference in dying from prostate cancer when you get treated. This is after you know you have prostate cancer. You're assigned to get treated or not. So that gives you pause in terms of thinking about what's going on with that. Now, this is one of the many urology counterpoints. So Ed Messing, who's a good friend, is a urologist at maybe North Carolina, I can't remember for sure. Anyway, this is a curve looking at the number of patients who present with metastatic disease, and here's where we started doing the screening. And many fewer patients are presenting with metastatic disease per 100,000 men. And this is, I think this is among Caucasians, and this is among African American men. And it's true. When Jack and I were interns 100 years ago, most of the time when you saw somebody newly diagnosed with prostate cancer, they came in with metastatic disease and bone pain and got started on hormone therapy. So clearly we are treating a lot more earlier stage disease. The question is, you know, really whether that helps. And then this is sort of I thought a nice slide that was from the PIVOT trial. Only 13% of the initial study cohort with a baseline erectile function. This is, I told Patty today that every guy who says his shim score is 25 is lying, especially in this age range. Because if you look at family practice and the sexual health inventory score, below 15 you start using Viagra, for example. And guys in this age range who say they have 25s are lying. But anyway, so only 13% had returned to that score post-operative. So there's, you know, I used to say to people a 50-50 chance with nerve-sparing prostatectomy that you're going to still get erections when you get done with your surgery. And it's probably not that good. I mean, these people, you know, not getting back to 25 is one issue, but there's no free ride when it comes to erections. So all of this leads to the question of whether our urologists, who are now 85% of the cancer surgery on prostate done last year in the United States was done robotically. There are no particular advantages to robotic surgery except to the urologist. If you sit at the console, your back doesn't hurt. It's a very difficult operation. I don't know if any of you have ever scrubbed in on prostate surgery. It's down behind the pubic bone and long instruments and tying knots when you can't see what you're doing, trying to hook the base of the bladder back to the urethra and stuff. Very difficult. And this clearly makes it easier. But the things patients care about are continence, potency, and cure, and those haven't improved much. You get out of the hospital a little sooner, pain scores are a little less, blood loss is a little less, but not the great advance that we'd like it to be. So that's kind of a quick overview of primary prostate cancer. And I think the take-home message there is that we still are not very smart about how we screen and how we treat early-stage disease. There are several new concepts in hormone therapy. We had thought that intermittent therapy was equal to continuous therapy. There were 7 studies that showed that, and for the last decade and a half, I've actually had most of my patients who weren't on clinical trials being treated intermittently with androgen suppression using typically Lupron and Casodex, for example. It's better tolerated, potentially less bone loss. And then this study, which started in 1993 by the Southwest Oncology Group, which was the largest study reported to date, was reported out in May and showed that continuous therapy was actually a little bit better in terms of survival than intermittent therapy. So that's kind of changed what we do. There are lots of other studies in the hormone area, but conceptually, it's now clear that every time Dr. Hardenberg adds androgen suppression to her high energy photon beams, the outcome is superior. So there are no studies that show an inferior outcome. There's a few that show not much effect, but the most recent one was adding Casodex to intermediate risk patients with radiation therapy, and it worked again. So 150 milligrams of Casodex a day. Was that salvage or primary? Primary care. And yet again showed a survival advantage with a fairly mature study. And worse news for men who like to have testosterone. This study by Michelle Bola in the New England Journal looked at 6 months of treatment with high risk, locally advanced disease versus 36 months of treatment, and all the patients got the same radiation therapy, and you were better off taking hormone treatment for 3 years than 6 months. 6 months had been previously shown to be better than no treatment. So, guys, I'm sorry, but testosterone is not good for you. Causes wars, causes people to go to the fiscal cliff, fight with each other. With metastatic disease, there's a pretty interesting story that has evolved. This study was published in 2008 by Bruce Montgomery in Cancer Research. And it turns out that for some time now, maybe as long as 15 or 20 years, there have been some odd things. So if you take dogs or rats and castrate them, it turns out there's still testosterone around. And some of it was thought to come from the adrenal gland. But these are patients who have been on both blockers with Casodex and Lupron and looking in metastatic lymph nodes from one of these hormone refractory patients, and it turns out that the androgen receptor is still expressed. The PSA is still there, which is an androgen-driven gene product, as is another androgen-driven gene product. So where's the testosterone coming from that's driving these genes that are androgen-sensitive genes? And the short answer is it's coming from the cancer cells learned to make their own testosterone. Pretty interesting, considering we thought that only the glands in the adrenal and the Leydig cells in your testicles could make testosterone. So this is the androgen synthetic pathway, and it turns out you can use this drug here called abiraterone, Zytiga, which will inhibit 2 of the enzymes responsible for going down this pathway from cholesterol to pregnenolone to DHEA and out to testosterone. The problem is when you block them, it also blocks cortisol production. ACTH levels go up, and it stimulates this part of the pathway to aldosterone going down, corticosteroid going up, and you can get hypertension. But you can give people a little bit of cortisol along with this drug, so people get 5 milligrams of prednisone BID and do not get hypertensive and do not get hypokalemic. And abiraterone was approved about 18 months ago based on these data. So this is maximal PSA change in patients with metastatic castrate-resistant prostate cancer patient who had already been treated with chemotherapy, very end-stage patients. And, you know, well over half the patients had a more than 50% drop in their PSA at 12 weeks, and the maximal drop was significant. So these patients clearly respond, and it's thought that most of that is due to the cancer cells making their own testosterone. And fortunately, this is sort of funny. This drug was developed by Cougar, which is kind of funny. And Cougar is a company from London, and it moved to the United States to do these studies, and I got to be one of the data managers for this trial. But this was the first trial, so it was first approved based on this trial for people after chemotherapy and showed about a 4-month improvement in survival with very highly statistically significant data. The next study, which was Cougar 302, showed the same thing in patients who had not had chemotherapy. So as of 10 days ago, actually, the FDA approved this for patients who've not been on chemotherapy yet. And there's some stories about how our committee worked on that. The data on the 302 study was presented at ASCO this year, and a statistician who I dislike intensely stood up and said our committee stopped the trial early, and it had the same p-value of 0.0001. And she said, you did not cross the Fleming boundary, and so this study has a 1 out of 4 chance of being a negative study. I'm like, give me a break. It's like, I hate statisticians. Anyway, so here's the other people I hate, the drug companies. So Johnson & Johnson bought Cougar for $1 billion about 2 years ago. You should have invested in Cougar when it was still $5 a share. So abiraterone now costs about $5,000 a month for 4 months increased survival. Another drug that we won't talk about, a vaccine that was approved about 3 years ago, Sipuleucel T, is $100,000 for 4 months of increased survival. We've looked at these two and published on this, cyclophosphamide and dexamethasone, that have probably equal PSA responses to this. And because they're dirt cheap and they don't get in the New England Journal and cause the stock market to go anywhere, these were published in irrelevant journals. But there are some cheaper alternatives. But we'll keep our eye on this table as we go along here, because the costs of drugs in this country is shocking. This was the next drug to be approved. It was approved about maybe a year ago. MDV 3100, which is now called Xtandi, was developed by Charles Sawyers. Charles Sawyers is the head of research now at Sloan Kettering. He was given a $100 million package to move from UCLA to Sloan Kettering. He's a wonderful guy. If anybody deserves $100 million, it's Charles. So when he was at UCLA, he took Casodex, the drug we've been using for 20 years, and told the chemist, go off to the lab and make all kinds of cogeners of similar molecules, and we'll see which ones work in Casodex-resistant cells. And this was a drug that fell out of that. And it binds the androgen receptor and blocks dihydrotestosterone from interacting with it. But unlike Casodex, that's where Casodex ends, and the androgen receptor can mutate, and with Casodex attached can still go down and stimulate cell division. This one binds the mutated androgen receptor as well. It prevents translocation into the nucleus, prevents binding to DNA, and also prevents coactivators and co-repressors from binding to the transcription complex. So this is a pretty cool drug and works in androgen resistant patients. And the trial that led to its approval, I think it was in July maybe, but anyway, the trial was stopped in November of last year. They looked at 1,100 patients in this trial, placebo versus MDV 3100, and another 4 or 5 month improvement in survival with very statistically significant data. So here's what happens if you'd have been following that drug company. And somebody leaked the message here, and there's the stock price going from 18 up to now 80 as of May of this year. So that company has not been bought by another company yet. But when you are able to hit the market with a new drug, they decided they would ask $7,000 a month for 5 months improvement in survival. So the table continues to grow in a disturbing way. So the key points here are second-line hormonal therapies demonstrate responses in castrate-resistant prostate cancer, and the two drugs I've talked to you about, abiraterone and MDV 3100, which is Zytiga and Xtandi, both work. And we now have trials being generated, as you could predict, looking at which sequence is best and whether combining these two would be better. I think the most exciting thing to come out of this was from Dana-Farber last May, Phil Kantoff and Mary Ellen Taplin, who are terrific people, good friends, took 50 patients, 51 patients with advanced local disease, the kind of people we usually don't operate on. We send them to Patty, she puts them on hormones, they radiate. So these are Gleason 8, 9, 10 type patients with advanced local disease. And they gave them either 3 months or 6 months of the usual Lupron and Casodex, but added abiraterone to that. And there were, I think, 4 complete remissions, and 20 out of the 50 had near complete remissions. So the idea of giving anti-androgen therapy to surgery patients has been thought about for a long time. Never worked that well before, but now it's being looked at very, very seriously in large studies. So we may be at the point where we have neoadjuvant therapy, just like we do for breast cancer that's advanced, like inflammatory, et cetera, that really may make a difference in survival and outcomes, and that's pretty exciting, I think. We're going to talk just a little bit about stromal therapy for a second, but I want to show you another story. So if you have a small cancer, the conundrum for the patient is, do I get treated or do I watch? There are several large active surveillance trials that suggest, look, I mean, I already showed you if you treat it, it doesn't make any difference, except that you become impotent. So the question is, can you watch safely? Generally, the answer to that is yes, but a lot of patients do not want to live with this cancer. I mean, it's not fun to walk around saying, well, maybe it's going to escape today or become worse. So at the school, we have a program with targeted therapy, and I just want to show you a video of what goes on, because we've referred a number of patients down there. The question is whether this will work, of course, for this. So this is how you do the 3D staging biopsy. This is the same kind of template that's used for putting brachytherapy seeds in. And these are 5 millimeter intervals. And this is sort of bolted to the perineum of the patient, and volume measurements are obtained. And then a needle's inserted every 5 millimeters. They first do, the fiducial markers are putting in seeds to sort of mark where you're at. And then they start doing the biopsies through here, and it takes about 1 needle per gram of prostate. So a guy with an 80-gram prostate is going to end up with 80 needle biopsy cores. This is done, needless to say, under conscious sedation, but you're not on a respirator. So the patients go home with a catheter because it's pretty invasive. But the cores are then laid out, and you'll see in a second reconstructed. So here's the entire prostate with a core being placed in each area. And processing these is expensive. This whole process is about a $10,000 pathology undertaking. But once you do this, you can then put the where the cancer is at each end of the core is marked and so forth. Samples processed individually. 69 cores are being sent to pathology in this case. And then you can then put it into a computer program, and this is what that ends up looking like. So each millimeter or 5 millimeter slice is put here in this computer, and you can say where were the cores positive, and there's the cancer over there. At least a third of the patients have more than one cancer in their prostate gland. But if you have a small cancer and it's fairly localized, here's a patient with 2 cancers. These can be frozen using the same technique. You can now go back to B1, 5 millimeters in, put the needle in, and freeze that cancer. And the PSA will go down. And you can use that as a technique to treat the patient, so we're not just watching, we've actually eliminated the cancer. I view it as sort of setting the clock back to before this guy got cancer. On the other hand, saying this is like a male the equivalent of a lumpectomy in a woman with breast cancer isn't true, because then in the woman's case, you go ahead and radiate the entire breast. And lumpectomy plus radiation is as good as removing the breast in appropriately staged patients. In this case, we don't radiate the prostate because you get all the side effects you would have gotten anyway. So it's an interesting technique to keep an eye on, and we've treated about 75 patients who've had worse cancer than we knew about, so they wouldn't have been active surveillance candidates anyway. once you know what's there, you can make a better decision. And in those patients who chose to have a prostatectomy and then you go through and slice things, this mapping process is very accurate. It tells you with a high degree of certainty what's going on in the prostate. So a couple final ones. Prostate, like all cancers, is a seed and soil issue. The soil for prostate cancer is often bone. Radium is a bone-seeking isotope, and radium-223 is an alpha emitter. So it's very high energy. It's called high LET, high linear energy transfer. The particles only travel a few tenths of a millimeter, but they deliver an enormous amount of energy to whatever they hit when they disintegrate. So this was a study that was done clear back in 2007 and looked at treating patients with radium-223 who had bone metastases and then looking at survival, and it turned out that the survival data is positive. So this is the first time that a radioisotope has been used in patients with metastatic disease and showing a survival advantage when compared to placebo. And this drug is I can't tell you where it's at in the approval process. It's available on expanded access in the US right now. So I sent a patient last week over. In fact, one of our other patients here may end up going over to see Nick Vogelsang, who's at the University at Nevada Cancer Institute, to get this drug. And then the last one to talk about is sort of the interplay between, this is I think a drug company slide, but rank ligand and rank is a protein that interacts with the cancer cells so that you have this kind of evil system set up between the cancer cells and the bone to increase bone reabsorption and cause cytokines to be released from the prostate cancer cells that cause them to go back to the bone, et cetera. So this is actually one of the reasons prostate cancer ends up in bone. And you can interrupt this axis with a drug called denosumab. And it will reduce the number of skeletal-related events in patients who have castrate-resistant prostate cancer. So it was compared to zoledronic acid, Zometa, which we've been using for a decade or more. And looking at skeletal-related events, there was a hazard ratio favoring denosumab, but no survival or progression-free survival benefit, unfortunately. Also, unfortunately, just like Zometa, it causes osteonecrosis of the jaw and hypocalcemia. And for those women in the room who are postmenopausal, I'm not going to point any arms, but these fractures that happen when you take bisphosphonates, the femoral fractures that you've heard about, also happen with this drug. So if you take this as a woman with osteoporosis where it's approved, it's called Prolia. And if you take it as a man with prostate cancer, it's called, what's it called? Xgeva, thank you. All these Xgeva, Zytiga. Thank you so much. All right, so we add all these up, and we're now down to $220,000. If these are additive, we might add 2 years of increased survival, somewhat fewer fractures. And the question is, how can Medicare and our healthcare system afford this? And I don't have the answer to that. It really bothers me a lot because I have not been a big fan of sending patients for this. It doesn't affect their PSA. These are asymptomatic patients. If you have symptoms, you can't get this. And I think the data are accurate. I think you do improve survival, but these are expensive numbers. The tradition has been to compare a quality life year saved on hemodialysis. That's about $65,000 per year. It's probably, this is an old number, it's probably $75,000 or $80,000. But I don't see how we can afford this kind of cost, $110,000 per year of survival for men in their 80s. Soon enough I'll be there, so we'll find out if I live in it. What the pharmaceutical companies are doing are trying to see if we get more mileage by doing this earlier. So earlier intervention when the tumor burden is less, this is probably where we are right now. You can add the drugs I've talked about and improve survival by 1 or 2 years. And then they have this explosive disease that I talked to you about earlier, and we've seen a couple patients. But the question is whether if you did it much earlier, would you actually slow that curve and more and get it out? The hooker with doing these kinds of studies is I just put time on the axis down here. But from the time you start androgen suppressing therapy until you die of castrate-resistant prostate cancer is probably 10 to 15 years in most patients. And the patents run out on these drugs before that happens, and it's a ferociously expensive undertaking, and the pharmaceutical companies, nor those of us who are in the academic field, know what to do about doing that. But from Phil Kantoff's study, I would say that you could even do it back here and potentially make a difference in this disease. And the last one is just a gee whiz. This study is ongoing at the school. This came out of an abstract that was presented 2 years ago of a drug that inhibits one of the oncogenes called MET and vascular endothelial growth factor. Both of those can be inhibited by this particular drug. And it blocks angiogenesis and also blocks hepatocyte growth factor, HGF, which binds on the bone cells like this. And the shocking thing about this in a phase 2 study was this is what can happen to the bone scans in these patients. So this was 6 weeks later after that. Sorry, I turned this off here. 6 weeks after starting this drug, this bone scan normalized. And in the abstract that was presented, some of the patients' PSAs went down, and so the current trial that's underway is a 2-to-1 randomization to this drug versus placebo in patients who've been through everything. All the drugs I've talked about, they're now eligible for this trial. And of course, you can predict what the costs will be if this works, but it'll have to be a survival advantage. So in summary, we have this new era of hormonal therapy that's really pretty exciting. It's the first new things that have happened since we sort of started working on Lupron 30 years ago. And the androgen receptor is the driver mutation, if you will, for prostate cancer, just like the BRAF mutation for melanoma, just like HER2 for breast cancer, BRCA1 and 2, et cetera. And, you know, prostate cancer is this disease of aging that everybody's going to get if they live long enough, and we have these huge problems with cost benefit. And lastly, screening can save lives, but we still have financial and physiologic costs that we haven't figured out. So that's Prostate Cancer 2012. Thank you for your time.